Hi, my name is Riley Clark, and I'm excited to share with you this lecture about a revolution in full arch implantology. I'd like to say thank you to DIO headquarters, the full arch team. I'm really honored to be part of what you guys are doing to help the implant world up its game and become state-of-the-art and the standard for full arch implantology. So appreciate the invitation to be part of this, and thank you to DIOnavi. Before I jump in and talk about the revolution in full arch implantology, I want to share with you some thoughts on what I call the digital difference. See, my first maybe 1,000, 2,000 implants were all placed in a freehand workflow. I took CTs on them and I would analyze them, but I just would take that information that I got from the CT and I would go into the operating room and I would place the implants. Now, after a couple thousand freehand implants, I have switched my workflow to completely digital. I love digital workflows and their ability to augment and enhance my skill sets as a clinician. I was once in a consult with a patient who had done a lot of research online about implants. The patient asked me, "Hey, do you do implants freehand or guided surgery?" I was kind of surprised because I hadn't heard a lot of patients talk that way before. She clearly had been doing some good research. At that point in my career, I said, I do it either way depending on what the patient prefers. And then the patient asked me a funny question and said, well, which way would you want it done if you were getting an implant? And I quickly answered, well, I would want it done with guided surgery. Ever since that consult with that patient, I've decided I'm going to do it the digital way because I think the digital way in guided surgery is better. And if that's what I myself would want, then I want my patients to have the same experience. So I hope that we as clinicians are offering our patients the very best, the way that we would want to be treated if we were the patient. Let me share with you what I think the digital difference is all about. I think it comes into 4 categories. You have to look at it from a patient perspective, the procedure perspective, and the outcome perspective. And then something I call the restorative opportunity. Let's jump into this. There's been some research done that is in harmony with some experiences I have had. I've had a couple of patients come to me and I did freehand surgery. And then years later, they came to me and I did guided surgery. And the patients, without me even asking, said, wow, that was a better experience. That was easier. That was nicer. Wow, you're getting better, doc. But I had to tell them, it's probably not me getting better. It's I'm doing a better workflow today. So I found some research that actually was done on the same topic. And it found that patients who had experienced both computer guided and conventional treatments revealed that they felt less pain and a higher satisfaction with computer-guided surgery. So in today's competitive market for implants, if we can give our patients a procedure and a methodology that offers less pain and provides higher satisfaction, then we as clinicians should listen and offer that to our patients. So as we consider doing the very, very best for our patients, realize that guided surgery, I believe, is a much better experience for the patient. Now, the procedure. This is more selfish for me as the doctor. Now, certainly the patient enjoys the procedure being a little bit easier and faster, but for me, the clinician, doing guided surgery and taking digital technology and using it in my workflow has made a big difference in me and my enjoyment of dentistry. Frankly, the procedures are less stressful. They do not take as much clinical time, and they're often less invasive, less flaps, a lot more flapless surgery. Because they're less invasive and surgery doesn't take as long, often the cases heal quicker as well. And if a case heals quicker and less flap surgeries involved, I think there's a decreased post-operative infection rate. And so again, digital technology makes the procedure more simple for me, the clinician. Now let's talk about the outcome. Now, I don't know the story of these funny implant pictures I have on the screen here. These are not mine, thank goodness, but I found these on some dental implant websites. And apparently the outcome isn't always perfect. So if there's not a better reason to use guided surgery than the outcome, then I don't know what is a good reason. These are pretty bizarre. Hopefully we're not struggling with these types of outcome issues. If we are, we need to train a little bit more. But I will say that doing a lot of freehand implants, my implant placement was always not always, but it often was not as accurate as I would have liked. Maybe I was a little too close to the buccal plate. Maybe I was a little too close to that adjacent tooth. Maybe my angle was off a little bit. And as a dentist who's kind of a perfectionist like you, I want it to look perfect every time. And so if we can use technology and get a better outcome for our patients, then that is a very compelling reason to use a digital approach. In Stuart Fromm's textbook, Dental Implant Complications, he has this quote, and I love this. It says, "Complications related to malpositioned implants continue to be seen in implant dentistry and are perhaps one of the most common types of implant complications." Implant treatment is a very sophisticated treatment, and we charge the patients a lot of money for it. I think if we can avoid the iatrogenic, malpositioned implant and therefore avoid potential complications, then we are doing a great service for the patient who is paying a premium for a premium service. So again, one of the main reasons I'm a huge fan of guided surgery and digital technology, it helps me avoid complications by putting the implant in a more accurate position. If the implant is in a malposition, then it can cause issues with bony topography. And if we lose bone, the soft tissue will follow, and then threads are exposed. And once threads are exposed in the mouth, that can be hard to deal with. Also, implants could be placed so malpositioned that maybe the occlusal forces are not ideal, and occlusal trauma can occur, which could cause screws to loosen, an implant to fracture, porcelain to fracture, maybe even bone loss to occur. So as we put the implants where they belong relative to bone and relative to occlusal force, I think we have a better outcome long term for our patients. Now, my last argument why all of us should be embracing digital technology today is what I call the restorative opportunity. With digital workflows, we know where the implant belongs. That's different than freehand. See, freehand surgery, you have to take an impression to know where the implant is, and then you can talk about teeth. With virtual surgery and guided surgery, we know where the implant is before surgery even happens. So today, if we can find out the implant position before surgery ever happened, then we can do really compelling things for our patients like this right here. See, a surgical guide was built, but because we knew where that implant was going to go in the digital planning phase, we also could plan for a custom abutment before the implant was even placed. And because we know where the implant and the custom abutment is, we can plan a crown. So today, when clinically appropriate, a surgical guide and implant can be delivered to your office with a custom abutment and tooth that actually fit in the implant and relative to the adjacent teeth. That is very, very exciting that can all be done because of the digital workflow. And when I get on with my topic on the revolution of full arch implantology, you'll see this same principle, but within the realm of full arch implantology. So as we work towards guided implant surgery, I think we will find higher satisfaction for us clinically, our patients will be more satisfied, and our complications will go down. So if we can take good data, look at the data, analyze the data, come up with a very thoughtful plan, and then execute with guided implant surgery, then I think we're ready to enjoy a less complicated type of implantology. The other day, I was in Medford, Oregon, and I needed to fly down to Sacramento to give a lecture. That is only 324 miles door to door, so not a terribly long distance. However, that particular day, Delta, my airline, had some issues with flights. And long story short, I ended up going up to Seattle, then over to Salt Lake, and then over to Sacramento. That ended up being 1,937 miles door to door. I should have just gotten on a bicycle and driven from Medford to Sacramento. It might have been faster. Now, I want to relate this to technology for one last point, and that is, if we can use technology and do things efficiently, then we don't waste the time like this, going north only then to go east, then to go west, when all I needed to do was go south in the beginning. That created 6 times more travel than I needed for that trip. And I think with guided surgery and technology today, we can metaphorically take not a multi-stop trip like this in our dental workflows, but we can take a direct flight where we are efficient and effective. And so I'm a really big fan of technology. I'm excited that it can make us better and help us give our patients even better service. Now, let's take this awesome idea and foundation of technology and apply it to my personal revolution with full arch implantology. And with that said, let's jump right into this. I've had quite the story with full arch implantology. I'd like to review with you the different options out there and the different types of treatment that I've been part of. I've done a lot of implant supported, I've done a lot of soft tissue supported prosthesis. I've done the crown and bridge type without pink. I've done the hybridized type that have pink acrylic. I've also done a lot of overdentures, both on a bar type and direct to locator attachments. And so what I want to focus on, though, when we talk about full arch implantology, I want to talk about the very unique full arch system that DIOnavi offers. That is a hybridized type, meaning there are white teeth and pink soft tissue in the prosthetic. This is obviously a fixed restoration, and that fixed restoration is, in my opinion, the most ideal target when we're treatment planning these patients to restore function and confidence. I'm not going to go into the treatment planning. There are certainly treatment planning parameters that would require us to consider denture type restorations. However, I just want to focus on the workflow and the process in the short 40 minutes that I have to lecture. So let's jump into this a little bit. I'm going to talk about the DIOnavi full arch workflow. Here's my history with implantology, however. For the last 7-8 years, I have been doing hundreds and hundreds of cases of full arch implantology, and I've done it a lot of different ways. Here's just a few pictures showing some of the different methodologies and ways involved with full arch. I have been through a lot. I want to break down some of the facets relating to full arch implantology. If I had to tell someone who was learning full arch for the first time about the big milestones in full arch implantology, I would say these are it. We have the implant placement phase, the temporary teeth phase, the impression taking, the bite registration, the prototype teeth, and the final teeth. In my mind, these are the big 6 components to full arch implantology. I want to share with you my journey a little bit. If we want to talk about step 1, implant placement, I've done it a lot of different ways. I've done freehand, I've done guided, I've had soft tissue support guides, tooth support guides, bone support, bone reduction, and implant support with the 2-guide technique. I've done a lot of different clever techniques within the realm of implant placement for full arch. If we want to talk about temporary teeth, I've done dentures, I've done denture conversions, I've done implant mounts and a Seal-Tech matrix. I've done freehand teeth, I've done lab teeth, lab milled, lab printed. I've picked up the teeth, meaning creating a fixed type restoration. I've also locked them on, I've cemented them on. I've used temp cylinders, custom abutments. I've even had to use no teeth for some cases. So I've used a lot of different scenarios within the teeth phase. If we want to talk about impressions, I've done open tray, closed tray, PVS, polyether. I've done it with a wash, with no wash. I've built verification jigs. I have done verified impressions, digital impressions. I've taken impressions at abutment level and of course implant level. I've done scan bodies, custom trays, triad with wash. I've tried a lot of different techniques. We want to talk about bite registrations. I've used bite blocks that float, snap-in bite blocks, screw-in bite blocks, healing abutments, sectioned temporaries given to the lab to mount against. I've done no bite. I've tried digital bites and hand articulation. I've done a lot in the bite registration world, which is a very big topic and a very big obstacle in full arch implantology. I've done no prototypes. I've actually done denture setups for fixed restorations, even though it was going to be a lab milled restoration. I've done PMMA, I've done zirconia temporaries, I've done chairside fabrication of temporaries. And then final teeth, I've done it all. I've done acrylic, PMMA, zirconia, PEEK, pectin, resin, porcelain, Emax, printed, milled, pressed. I've done it with bars, with no bars, with multi-unit abutments, screw retained, cement retained, telescopic copings, custom abutments, even stock abutments. So, sorry, let me go back to this. What's the point? The point is my journey with full arch implantology has been very ambiguous. It has been a little bizarre. I've tried it this way, I've tried it that way, and I haven't found up until recently a singular type workflow that is consistent and constant for me in my office. And so what I'm about to share with you, I'm going to show some slides of maybe how I used to do a case, and then I'm going to show you where I'm doing it today. So here's my history. A patient would show up like this. We would treatment plan them for full mouth implants. I would take a few teeth out and place a few implants. That way the implants were as good as I could guess in a pretty good position relative to the prosthetics. I would continue placing a few implants after I took out some teeth, and I would continue the process until all of the implants were placed and all of the teeth extracted. Then I would bone graft around the areas with PRF, and then I would begin building temporaries. And often I would build temporaries like this. I would run some flowable composite along my surgical mounts of the implants, and then I would fill up this putty with a temporary material, and I would lock the temporary onto these surgical mounts that were on the implant. It looked kind of cool and it was clever at the time, but the problem, it didn't have a great workflow from there. So they looked okay. However, I would eventually have to cut off the temporaries, place impression copings, take an impression, design some type of way to get a bite registration. I would build a verification jig, and then when I had all of that good data to give to the lab, I would have to then make brand new temporaries all over again, and then the lab would start designing teeth all over again from scratch. It was not a very effective or efficient workflow. That's what the temporaries might look like. I would then have custom abutments in the mouth, and eventually, after a lot of prototyping and adjusting, I would have some type of prosthetic like this. And this prosthetic looked good, but in order to seat it, I was working off of an actual model, not in a digital workflow. And I don't like these analog workflows because they are not nearly as predictable and they leave opportunity for more complications to arise, in my opinion. I would adjust the teeth so they would fit passively. I would try them in, you would mark wherever there was some friction, and then I would adjust it. I prefer not to adjust zirconia, but sometimes you have to. And then I would cement these, and I'd have to clean up all of this cement. And cleaning up the cement is a tedious process that we know can be very harmful if we don't clean it up properly. We can leave residual cement, and so that was something I didn't enjoy. Now, I could still produce a good-looking result. The patient liked how they looked, but the process from where I started surgery to where I finally am reaching the finish line had a lot of left and right turns and was not very efficient use of time. We backtracked a lot and had to redo things, and that for me was very, very frustrating. Now, let me be more specific. Let's go back to a step in this process I just showed. When I built these temporaries and locked them in place, the question is, what do I do now? How do I take where the patient is currently and effectively and efficiently move them to their final restoration? How do you take them from there and get all of that data to the lab? I've done it a lot of different ways. I've done it with dentures. I've done it with lab-made temporaries. I've done it with clever guides that are bone-mounted. No matter which way I did it, I really struggled getting all of the relevant data to the lab so I could efficiently and effectively build the patient with their final teeth. What do you do now? And here's where the magic starts to become better understood. Basically, the question is, how do I transfer the implant position, the vertical dimension of occlusion, the tooth contours, the smile line, bite registration, and soft tissue contour all to the lab? How do I do that? Well, here's how I used to do it. I would have to take different data sets to obtain one of these important diagnostic factors. So for example, for the implant position, I would have to take a fixture level impression. To reestablish the vertical, I would have to use a bite block. To have the lab help copy the tooth contours I created for the patient, we would have to take pictures or an impression of the teeth. To understand where the smile line is, I would have to take more pictures. Bite registration, hopefully a bite block or some clever idea, maybe of their old temporaries or something. And then how do I capture the soft tissue? Maybe another impression. So the point is, all of these relevant data sets would be coming from unique, different diagnostic tools like an impression or a bite block or a photo. And so I would have all of this data that the lab needed, and their job was to correlate it perfectly with one another. The problem was, as you take all of these data sets and try to line them up as to create a very clear understanding of the situation, they wouldn't always line up perfectly. And because they wouldn't always line up perfectly, sometimes things were off. Sometimes things were off a little bit, and sometimes things were off a lot. Look at this. That is not the right bite, obviously, but that's what it was because something obviously didn't get lined up right. So today, I have such a better workflow that takes you from point A to point Z, not only digitally, but does it effectively and efficiently in a linear type workflow, not a U-turn or a left and right workflow, but in a linear type path. And I'm excited to share that with you right now. So here is my full arch workflow today. Step 1 is diagnostic gathering, 2 is digital planning, 3 implant surgery, 4 fixed provisional, 5 provisional scanning, and then 6 final delivery. What is so neat with this is my planning from step 2 complements step 5. And what I mean by that is we're not planning some teeth early in the diagnostic phase and then giving up on that design and starting from scratch as soon as a final impression is taken. This workflow works in a linear path building off of each step. Let's jump into it. I also want to mention what's really cool with my workflow. It all shows up in one box. And all in this box is my complete case. Everything from surgical guides to prosthetics to abutments, temporary cylinders. The entire case is right here. And I love that it's just easy and clean and simple for me and my staff. So digital planning, I don't want to get into that too much, but it's important we start with a very thoughtful digital plan with the final prosthetic in mind. We have to know where the final teeth belong before we begin planning our implants. And so a very thoughtful diagnostic phase of planning the teeth and then planning the implants to match the teeth is very, very important. Placing the implants is a piece of cake with this workflow. With guided surgery and with the accuracy of the DIOnavi system, we're able to place these implants quickly and accurately. And that's a powerful combination for us, the clinician, and of course the patients themselves. The DIOnavi guide system is also very unique in that it has a timing index where we can make sure the rotational timing of the implant is ideal for hexed abutments. And that's really, really neat that they've taken all of this into account within the planning and the guide fabrication phase. Here's some multi-unit abutments. Here's what it looks like without the healing abutments in place. Multi-unit abutments go into the implant and bring basically the platform to the tissue level. We're then going to build teeth at the platform level onto these multi-unit abutments. So here the multi-unit abutments have been placed. The temp cylinders are in place. And the provisional, sometimes by the way, this is a clean case. You can do this also day of surgery. So day of surgery, you can put all of this together. And if there is a lot of blood that's making it complicated, this little rubber dam trick is nice to help it not interfere with the pickup of these impression copings. Everything is lined up beautifully in the lab. You can see here the front 5 implants are multi-angled abutments that in the planning phase have all been planned to line up ideally. And you see the white handle representing the straight multi-unit abutment. So here you're seeing a variety of cases. You can do it after healing phase. You can do it right during surgery. You can do it with straight abutments. You can do it with these angled abutments. But the point is, once you get the cylinders in place, you take the lab-made temporary like this, and we will seat it in the mouth, and we will have a proper relationship from the surgical accuracy of our guide and the temp cylinders relative to the temporary. This right here is the magic. Look at the accuracy for everything to line up so beautifully from a planning phase. So I really like what I'm seeing here. We are now ready to use this palatal rest to maintain the vertical of our case, and that seats the provisional bridge exactly where it belongs. I then inject some type of dual cure resin or acrylic, and I lute the provisional to the cylinder. This is what it looks like after the cylinders have been brought in and attached to the actual temporary. What's nice about this, now we have created a screw retained temporary. Those cylinders are screwed into the multi-unit abutment, and the cylinders are attached to the temporary. By undoing the screw, everything can come out of the mouth just like this. Then, additional material is added to fill any of these void areas around the cylinders. So more material is added, and now it's filled in beautifully, and it's ready to get placed back in the mouth. So that's the provisional bridge workflow. Now you might say, well, that's not a new workflow. I know all about that. That's how we do temporaries. Well, what is so cool with this workflow, all of this good work of seating the multi-unit abutments and placing the cylinders and hooking them up to the temporaries, all of that effort directly influences and affects the final restoration and the impression workflow. So what do I mean by that? Let's ask the question again. How do you transfer these important parameters to the lab in a case like this? Do I go back to my old workflow where I take impressions of this and pictures of this and bite blocks? I do not. With this really cool digital workflow, the way I do it today is a scan of the temporary. So how do I capture all of this data? It's all a scan of the temporary. Pictures are still necessary because the pictures help us communicate with the lab of potential changes and modifications that we might want. So how do we scan the temporary? Well, let me talk about this for a second. With my old workflow, I would take all of these data sets and I would try to line them up on top of each other. Well, today, it's all lined up perfectly because it's coming from one data set. So my new workflow on the right that you see here basically takes all of these data sets and they are all within relativity of each other. And because of that, the accuracy of our data is superior, plus it is done digitally, so we can work faster, creating a beautiful, streamlined result in an effective way for our patients. So I used to use powder, and I would actually spray it into the metal cylinder and I would try to scan. I would create an impression like this. However, today there's even a cooler way of doing the scan. Today, I basically can do a reline impression and then screw these scan bodies onto the fixed provisional bridge. And then by scanning the scan bodies, it is a easier, more predictable scan than trying to use powder inside the metal cylinder. So today, this reverse scan body, as I call it, is the ideal way of scanning. But basically, the teeth are removed, and I can scan, after a reline impression has been done, the entire 3D object of the provisional bridge. And by doing that, I create not only a representation of where the multi-unit abutments are, but I also know where the soft tissue is, I know where the bite is, I know where the tooth contour is, I know where the vertical is. All of this is captured by scanning the provisional bridge. Now, I will say the technique in which we scan is very important. This is not meant for the new user of intraoral scanners. This is a sophisticated scanning technique and requires a lot of attention to detail in order for the accuracy to be sufficient for final prosthetic fabrication. So that's very, very important. This is a quick video that shows roughly how the scanning process works. I would like to skip ahead and show just a couple of components of how this works, and I'm going to skip ahead to about right here. So here I'm showing the prosthetic being relined, and now I'm going to capture the intaglio surface by putting in reverse scan bodies. Here you're seeing reverse scan bodies in place, and then the scan is done to actually capture all of this anatomy. Now you can see the scan needs to be modified slightly, but this scan is capturing all of this data in its perfect form. So I'm going to make that look a little bit more ideal, and let me skip ahead and show you what the final scan looks like. So there's the final scan that shows the teeth, the abutments, the bite, the vertical, the soft tissue against the opposing arch. And that is a wonderful final impression workflow. If you compare that scan right there compared to my traditional ways, where I had to take upper and lower impressions, I had to build verification jigs, I then had to use some sort of bite block to reestablish the bite, and then the lab had to make new temporaries guessing where my provisional bridge was relative to the implants. In this workflow, all of the material is in one data set. All of that diagnostic data is in one data set, making it easy and efficient for the lab to build the teeth that the patient wants and the doctor wants. This is a really cool workflow. So what does the lab do with that? Well, the lab takes that data and they now can reverse the image of the implant temporary scan, which gives us the multi-unit abutment position and the soft tissue position like seen in the top left. And then on top of that, they can put the tooth position and the bite information in, and now they see the entire case on a computer, both from a soft tissue and implant perspective, as well as a tooth and bite perspective. Sometimes an additional scan of the soft tissue might be needed and helpful to help confirm the accuracy of these positions. So if needed, take an additional scan of just the soft tissue. Now, with clinical photos and all of this diagnostic data, the magic is this: they can begin to make changes relative to the temporary that is already in the patient's mouth. So that picture on the right might be one of the most important pictures of my PowerPoint presentation, because it helps you realize that changes are made relative to the teeth that we have already planned from the very beginning. So we're not starting over. It's not like we're throwing out the old design and starting fresh. Changes and modifications are made relative to the original plan. And that is where the power of efficiency is really highlighted, because like I said earlier, we are working now in a linear type position. We are going straight ahead, not making steps back and doing U-turns to try to fix things. Now you have to ask yourself, with that scan, are you going to make a new provisional bridge, a new temporary, or are you going to go to final teeth? That's a clinical decision that you as the doctor has to make. For me, my decision is basically based on how severe the changes and modifications are to the original provisional bridge. If I'm making just minor or small revisions, then I typically will go to the final teeth. If there are large changes being made, or the patient has a very demanding want for her final or his final teeth, then that needs to be considered, that maybe it's a safer route to build another temporary. But basically, once all of that data has been captured, you can build a new temporary or you can build final teeth. It's completely up to you. When you do go to final teeth, a wonderful metal framework is designed that fits directly over the multi-unit abutments as shown on the right. And then on the left, you're seeing the restorative material bridge being placed on top. That material could be zirconia. It could also be DIO's very strong printed resin, PMMA type print that they have. So the restorative material can be changed based on the clinician's wants and maybe the patient's want, maybe even budget might influence that decision. But the final teeth will be made with a metal frame and then a prosthetic bridge that goes on top of that metal frame. And then pink porcelain or resin composite will be placed on that to create a hybridized prosthetic. So here you're seeing it in occlusion with its design. And then here you're seeing it in person. So that is a monolithic zirconia restoration. And that zirconia product today is beautiful. You can see wonderful anatomy in it, even some translucency in it. Patients are very happy with that. And because this is a hybridized restoration, the pink resin has been placed here, creating a very beautiful tooth and soft tissue relationship. That is why this, when I showed that original slide of the different full arch options, this option I think is superior because its ability to control the soft and hard tissues and their appearance in a hybridized type restoration. So beautiful product. Here's a few pictures of a case I did. I kind of teased the patient. He's got a beautiful set of teeth on top, but didn't want to do anything on the bottom, and that's okay. But beautiful set of teeth here. You see there are some cantilevers on this particular case. I prefer typically not to have cantilevers, but sometimes we do. But beautiful restoration. The bite is spot on. The aesthetics are beautiful. Patient really was happy when a product like this comes through the door. I'd like to thank you so much for your attention, and want you to know that this workflow today not only makes the clinician's life happier and easier, but it gives our patients a better opportunity to experience full arch implantology. No longer are we making constant changes to temporary teeth, but we're able to deliver them in an efficient and effective way, the final restoration based on their provisional bridge. I appreciate your attention. If you have any questions or concerns, feel free to shoot me an email. I'd love to hear from you. Thank you.